So what we're reviewing, yes ma'am. Yeah, I think it's because
You gotta say it again.
That's why really.
Okay, any better? Or, okay. Thank you for letting me know. Okay, a little review from infectious disease yesterday. So if we were talking about diseases and you had another student come to you and say, I think I just saw 4 timer spots. What disease would you think that that student is seeing? Not measles. What's in measles? Coplet spot. Yep, so what are 4 timer spots go with?
Measles light.
Not rubeola, because that's the same as measles. Rubella, there it is. Rubella. Okay.
German measles.
Take it back. Rubella. Okay, what is the first part of the rash for parvo B19? Black cheeks, yes. And does it desquamate? No, I just wanted to make sure we covered that again, yes. If you had congenital rubella syndrome, what is that congenital heart defect that's associated with that most often? PDA, correct. Okay, this weekend, your neighbor tells you that they just got a puppy. Isn't that cute? And that the puppy has parvo, and your other neighbor is pregnant, and your pregnant neighbor is 35 weeks pregnant. Are you concerned?
No.
Why not? Because people are just saying there were 2. Yeah, so second trimester, not third. What is your underlying cause of roseola? Yep, human herpes virus 6. If you think of half a dozen roses, 6 roses, human herpes 6, it's 6th disease, all of that goes together. Ray syndrome. Ray syndrome is associated with a drug and a childhood disease. What's the drug? Aspirin. What's the childhood disease? Varicella. What do you use low dose of amoxicillin for from here on out? Group A. What is your first line treatment for scabies? Yeah, ivermectin. No, what was ivermectin for? Your second line for lice. Okay. So from here on out, I know ID is its own class as well, but it kind of mixes there. So from here on out, we basically go system by systems of heat, pulm, derm, cards, GI, or GU, all the different systems that we're going to be going through. So it's a twofold thing. Number one, it's going to hit some of the wave tops again to remind you, yep, I got that anatomy, the physiology, some of those high yield things, because you've had those courses. But what I want you to focus on are a couple of things. Number one, do you know those wave tops again? Because if you're like, oh dear Lord, I don't remember any of the eye anatomy, maybe brush up on some of that stuff. But then 2, this is not heat again. This is not GI again. This is not cards again. So I'm not going to test you on that. I'm testing you on what is the same in kids or what is different for kids. So that's what the focus should be as you're studying this is there's going to be some things that are the exact same thing with children, and then there's going to be things that are different and you treat them different. So that's what I want you to focus on as we go through these different systems. So we're starting with heat though today. I have a soft spot in my heart for the eye. So I just love the eye. We will start there. This is a long, I know there's a lot of slides that this lecture goes today and on Monday. So I'm not trying to get through all of that today. Do not worry. Never fear. There's a lot.
All this free time.
Okay, so when you are looking at the anatomy of the eye, in a lot of these things, I will just put an anatomy review slide. We are not going to go over the anatomy again, but it just orients you as we go through the different systems. I also need to remind you that much like nephrology versus urology, that I swear we're going to get someday here, there's a difference between optometry and ophthalmology, and it's a little bit different even for children. So optometrists are doing the medical portion, ophthalmology are doing the surgical portion. The problem with that is that even though most childhood disease, especially in babies and young children, is more medical than surgical at first, there really isn't much pediatrics taught in optometry. So really under the age of 3, every child is going to go to ophthalmology. So they are going to go to the surgeons for medical and surgical disease. Okay, so if you're picking that for different tests, remember that the younger children are going to have to go to ophthalmology because those are the ones that get training for children. Way back from block 1. He said babies come out, they've been swimming in the amniotic fluid for 9 months, no light, so you come out functionally and legally blind. So anywhere from 2200 to about 2400. And as they're exposed to light and that visual stimulus, their vision rapidly will start to crisp up. So that's thing 1 about the eye. So that should be feel a little reviewy. Second thing, when we talked a lot about colic in block 1, well, they're crying, but they really don't even start producing tears until they're at least a month old. So anywhere from that 1 to 3 month mark is when you actually start producing tears. So a lot of the times if you have a young baby who's coming in for a neonatal fever and you're trying to assess for neonatal sepsis and hydration status, you could potentially have a 2-week-old baby with fever and you're saying, are there tears? And the parents say, no, there's no tears, and you conclude the baby's dehydrated, or the baby hasn't started to have tears yet. And so you can see that sometimes knowing when those developmental steps is going to change really what you would think for that management. At the very first part, the infants are going to just start to recognize faces, and really mostly who's going to feed me. So that's their big visual input there. Once they are able to sustain a little bit on an object, they can start, and then by the time they're 2 months old, be able to visually track or fix and follow. So it's one of those 2-month milestones. If you have an object, does that baby, are they able to follow it all the way around in 180 with both eyes? So not one going over here and one going over there. Remember that was disconjugate gaze, and you needed to refer them and by the time they were 6 months. Googly eyes up until about 4 months, still normal, still there at 6. I send them on their way to ophthalmology, not optometry. Everyone's going to check that red reflex. And again, just to correct myself, leukoporia, not leukorrhea, for that as yesterday. So that's going to happen for everybody. Things that we're going to look at for every child that's going to come in, as we're able to. Do we have symmetry of the eyes? Are they in alignment? We're going to talk about what that means. Are the eyes looking at the same place? Are they able to fix and follow? Are the pupils the same size? Can we get a visual acuity? We used to only be able to do the Snellen charts. So I think when I was in school, it was like, well, we really can't check vision until they're about 5 years old. You can read the Snellen chart. And the visual screeners where they take a picture of the cornea have really changed that. So now we can go down to 6 months. So we're really able to pick up a lot of eye disease a lot earlier. And a lot of clinics that you might go to, they have just quit with the charts completely and they'll use the visual screeners even for the older kids. That's what I would prefer, but Snellen charts, if you are able to read, you can try those. So when you get up into normal vision, so from the time you are born until the time you're about 6 years old is how long it takes to go from I'm legally blind to I have 20/20 vision. That means there's somewhere in the middle along the way where they have normal vision for their age and development, but it is not what we consider obviously 20/20. We'll talk about what that is. And as a reminder, that the most severe and frequent that we see that visual impairment is from retinopathy of prematurity. Do you remember how many weeks that was usually affecting? Less than how many? In the 30s, yes. Less than 32. Less than 32 weeks is typically when you see retinopathy of prematurity. I don't love the rule of 8s. I'll show you, I'll just tell you how I was taught as well, but the rule of eights is a way to say their age plus what is what their vision should be. So if you have a 2-year-old and you need to get to 8, 2 plus blank equals 8, so 6. So a 2-year-old's vision should be at least 20/60. That's how the rule of eights works. I never did that really for a 2-year-old. We used them more for 3-4-5, and 3-4-5 are just inverted. So a 3-year-old should be 20/50, 4-year-old 20/40, a 5-year-old 20/30. So however you want to get to what you know would be a normal visual acuity for a kiddo is totally fine. Rule of eights works, straight memorizing works, but please be aware of that to know, do you need to refer? Who are you going to refer to? So if you're not meeting this, let's say I had a 5-year-old who's 20/50. Do I need to refer that 5-year-old? 5-year-old?
Yes.
Yes. Right. I need to refer that 5-year-old because they should be at 20/30. What if I have a 5-year-old that's 20/30 in one eye and 20/50 in the other eye? Do I need to refer that 5-year-old?
Yes.
Yes. If I have a 4-year-old who is 20/30. No. They're overachievers. Okay? So a 2-line difference is when you would refer, or if they're not meeting that baseline for their age. So let's say I have that same 5-year-old, he's 20/30 in one eye, he's 20/40 in the other eye. Do I need to send that 5-year-old?
Yes.
2-line difference. So 20/30, 20/40. No, that's 1 line. So I don't need to send that 5-year-old. I need to follow them up in 6 months. Okay? 2-line difference. Reminder of those general definitions: hyperopia versus myopia. Myopia, I can see things close, I can't see them far. Hyperopia, I can see them far, I can't see them up close. In children, both of these are going to present as I'm having trouble in school. And that's why one of your first things for I'm having trouble in school is to do a vision test. The history will specifically matter. If you have a child that comes in and is having trouble learning to read, or says, I hate reading, I have no interest in reading, it's boring, I hate this. Is it because they're hyperopic and they can't see up close? They cannot see the letters. That's a little bit different than I'm having trouble because I can't see the board because I'm myopic. So sometimes taking a good history will help differentiate, are you nearsighted, are you farsighted, before you even do that procedure. But again, both will come up with, I'm having difficulty at school. So that's how I've seen that question always for boards is, child reports they're having difficulty at school. What is your first intervention? What are they most likely to have? Some of my favorites. So amblyopia and strabismus. Your brain is trying to take a visual picture from both eyes, takes it to the optic chiasm, switches it, inverts it, switches it back, flips it again, and your brain gets that visual input. Love those neural pathways, right? Those pictures that your brain is taking from both sides should merge and be the exact same picture. That is how your brain sees it and does peripheral vision. Makes sense. If your vision, if your two sets are not coming together to overlap and make that perfect image together, the brain is going to say, I don't know what to do with that second image. I'm just going to shut down that part of the brain, and I'm only going to take the crisper and the better version of that. And that's what happens with amblyopia, is eventually the brain just starts to shut off because it's not getting that visual stimulation. So strabismus, when you're looking at strabismus, you're looking at the eye movement itself. When you're looking at amblyopia, you're looking at the part of the brain that that visual input is going to and is shutting down. When we say misalignment of the eyes, that actually means something. It's not just like, well, those eyes look kind of funny, right? We've all seen people where you're like, I don't know which eye to look at. And we know they're misaligned, but how are we figuring out what test do we do to actually see the alignment of the eyes?
Cover test?
Not the cover.
No.
Yes, the first words test, or the corneal light reflex. Light right in the middle. Is there a light reflex that is coming directly in the middle of both pupils, slightly medial to that? That's how you're checking actual visual alignment. So they should be aligned. Happens a lot in kids because this is the first time their brains are seeing this visual input. why it happens more in kids. And if it's not corrected from the eye, the coin toss of if the brain's going to shut down or not. So you have up until they're about 8 to fix this. So this is one, if you see the eyes are not in alignment, they are over the age of 6 months, early intervention is going to be better for that. So in that nomenclature, when you're saying which eye is affected, how do we know? We're going to talk about those tests again to see what you remember from, when was that, sophomore semester? Way back in the day. So if we're looking and we're naming, if the eye is going to the nose, ESO, eye is going out, exo, eye is up, hyper. If it's fixed, meaning it's all the time, tropia. If it phases in and out, aphoria. So aphoria is phase. And yeah, you'll see this a lot with kids. When do you think it happens more with kids? Right in the morning when they're wide awake, when they're really tired and they're about to fall asleep? Tired and fall asleep. So that's a lot of times if you're trying to get this with kids and parents are like, no, it happens sometimes. That's a big distinguishing question. Does it happen when they're just bright-eyed and bushy-tailed, or right when they're about to fall asleep and take a nap? More likely then. Yeah, we talked about amblyopia. So 3 different types then of how then the brain will eventually start to shut off. So strabismic refractive deprivation from those things. So strabismic, I look at their pupils are not in alignment. I can figure out which eye is off. Eventually, because that eye is off, the brain is going to shut down. So that's kind of the classic type where we see strabismus leading to amblyopia. The second type is if you have an extreme difference in the eye, or both eyes are extremely myopic or hyperopic, and the brain is not getting that visual input. That could be a second reason that the brain just shuts off. The third reason is that deprivation. So the way that I saw this, so yes, we've seen some of those. There's a really interesting case where a child had a large hemangioma, and the hemangioma grew so much that it grew over the visual field. And so that child, even though later the hemangioma involuted, for that period of time, there was really no sensory input from that side, and it became a deprivation issue leading to amblyopia in that case. But anything that's going to cause that visual picture to not come into play. So we have already talked about retinopathy of prematurity. Again, don't pick that if it's not a kid who was born premature. Anything where that visual pathway is obstructed. So what class of patients, what genetic set of patients were more likely to have early cataracts? Yeah, trisomy. So if I cover the one that's affected, if I cover the bad eye, what does the good eye do? Nothing. It stays exactly the same. So I cover it, nothing. Uncover it, nothing. What happens? Still my bad eye. I cover my good eye. Yep. It's basically like the bad eye is like, okay, fine, I'll do something because you're making me, right? That's covered. What does the patient present like who's got a positive cover test? What do their eyes look like? They come into
misaligned.
Malasia, yeah. They have atropia. It's there all the time. So they truly have atropia. So for the cover test, you have the patient that's coming in with atropia, and you're trying to figure out, is it the right side or the left side? That's what you're trying to figure out. For the cover and uncover test, this is when they have aphoria. So you're like, I don't know which one. And I don't see it all the time. I'm trying to induce it. So again, this is my bad eye. I cover the bad eye, what happens?
Nothing. Looks the
And
same.
then I undo it, then what happens? Then it goes back. Yep. So I cover it up and it's like, oh thank God. And then when I uncover it, it's like, oh, and it comes right back. Okay? That's what's actually happening with cover and uncover test to see. If I do it with the good eye, and then I uncover, what happens? It's funny, during block 2 tests, people are usually like, it's always funny to watch. So, cover and uncover, just as a reminder, another way to do that, but you guys all did it.
No, I'm really subconscious about it.
Okay, so cover test. The patient's coming in with atropia. It's there all the time. You're covering the good eye, and the bad one snaps into place. Things to know about your ESO and EXO, those are going to be your most common. If you have a hypertropia, really something that you should call somebody because something's not right. That's never going to be right. But your esotropia, a lot of times going to be a congenital in nature, so they're just not getting that visual stimulation for that one eye. When it's happening in those toddler years, so they're fine at first, then it's starting to happen, that's usually when you're seeing more of the refractive error. When I was coming through school, it said we had to do something and intervene all day, every day. How long now are we having to do some kind of patching? Anyone have a guess?
It's like a year?
How long per day? 6 hours, 8 hours? 1 hour. That's how amazing children are. Like, you do something for 1 hour and their brain's like, oh, okay, I got it. Like, sounds good, thanks. So it's not something that they're necessarily having to do all day. You see benefit with down to even 1 hour. Certainly if you can do it longer, that's great, but some kids are just not having it. So do you patch the good eye or the bad eye? Why are you patching the good eye? That doesn't make sense to those people. You're forcing that bad eye to say, okay, fine, I will be the one, I will give that visual input to the brain, correct? So anything that you're doing, you can patch the good eye. You can also give the kiddo glasses where you give a refractive error to the good eye and you force that bad eye to work. Or you can do atrophy drops to the good eye. So you functionally dilate it. So if kids are just like, I am not putting anything on my face, you can do it with drops as well. So a lot of different options with ophthalmology now. I get a little bit more concerned, I think, for an exotropia. That's not what I typically see. So exotropia makes me a little bit more concerned, and there are times where I just intervene a little bit faster for an exotropia, but very similar, 2 to 5 years old kids that I'm looking at. Now, if you see a kid who, they're not between 2 and 5, they're older, so they were totally fine through their toddler years, totally good to go, and suddenly they come in, they're 7 years old, they're in 2nd grade, and now they have a new esotropia or an exotropia, that is a tumor until otherwise. Something is not right. There is a lesion that is affecting this that's not okay. So that would be an indication. If they made it through those toddler years and they're in school and this is new, that child needs imaging ASAP. So star, highlight that one. Late onset of this is going to be CNS disease until proven otherwise. Red reflex, everyone's going to get that. I've probably said this now 20 times in the course of block 1 and 2. So we've already talked about the reasons for that. If you start going back through your pictures, you'll see this sometimes. Anytime you see somebody who has cataract, you'll just end up seeing that white reflex. Do you know why I put this on there? AAP just got into, there's a real big thing for red reflex for a while. Okay, so when are you going to say, I need a full, true eye exam, or I need ophthalmology? Well, I'm going to need them if I have a true premature birth, particularly under the age of 32 weeks, because they have retinopathy of prematurity, and I need to make sure that ophthalmology is following this child until that retina is fully vascularized. So this doesn't necessarily mean that you're doing the exam, but ophthalmology is on board for that. The history of cerebral palsy or Down syndrome, again, what are the things that Down syndrome have? We talked about one of them today. Cataracts. What was the other thing that kids had? Grayish spots in the eye. What was it called? I heard it.
Cornwall spots?
Brushfield spots. Yep, those are Brushfield spots. And then anytime where you're having that poor school performance or school complaints, a full visual exam is the first thing. You see a kid with nystagmus, so even if it's not new, any kind of nystagmus in a child should at least be evaluated once by ophthalmology. Any strabismus that you are seeing and catching in clinic needs to go to say, do we need to patch or can we watch this? So anytime seeing or, and even really reporting strabismus, even if you can't elucidate it with a cover on cover, I tend to send, that's not one that families make up. Not to say that families make up diseases, but that's just really, that's not on anyone's mind to be like, their eye does this. So most of the time I send them anyway. And then an abnormal red reflex is I need to call like today, right now. Which takes us to conjunctivitis. So what are the 3 types of conjunctivitis? Viral, allergic, bacterial, there's a 4th. Chemical, yeah, chemical. Most common in kiddos makes sense, it's going to be because virus is everything, so viral and bacterial are going to be incredibly common. Remember we're talking about the conjunctiva, so we're not talking about the sclera. Most people will be like, oh, it's pink eye, and they're talking about the sclera, but we're, as clinicians, looking at the conjunctiva. It can be a secondary hyperemia in the sclera, but we're looking at the true conjunctiva. Things that we'll talk about throughout this is you have some duct obstruction sometimes. You can see this with sinus disease, and then we've already talked about allergic. It gives a secondary infection because kids are grubby, and then running all kinds of stuff into their eyes. Yeah, that was just a reminder of sclera versus conjunctiva and the different parts that we're talking about. Conjunctivitis, when you're looking at this, this is, again, in the conjunctiva, but making it the scleral hyperemia as well. Most of the conjunctivitis is true limbic sparing. So if we're looking right around the edge of the pupil, it spares that limbic area for the most part. That's one thing to know and document when you are looking at that. If you're thinking to yourself, wait, where was the limbus again? Here's the limbus. So most conjunctivitis in kid is limbic sparing. If it is not, your differential will broaden. You need to start thinking about something else for that kid. So you guys hit it perfectly. So first one, typically a chemical conjunctivitis, but it most of the time gets to be in a special category of neonatal conjunctivitis. So what they used to do, what did we use from block 1? What did we use silver nitrate to cauterize? Umbilical what? Umbilical granulomas. Yep. Did we say anything in that first neonatal period about using silver nitrate to cauterize the eyes?
No.
No. But that was what they used to do historically, is use silver nitrate to cauterize anything that they thought was going to be a Neisseria gonorrhea. Which makes sense then why you would get a chemical burn in the eyes. So there are still some places around the world that will still use a silver nitrate if they are thinking this is gonorrhea. So you can see how if you had a gonorrhea and you used a silver nitrate, you would end up with a chemical conjunctivitis in that. The other ways that you can see a neonatal conjunctivitis is if you truly do have chlamydia or gonorrhea of the eye and HSV. That's always HSV. For infectious, when we're talking viral, the one that I want you to really put in your brain is adenovirus. So yes, you can see it with some of the other ones, but your first thought should always be adenovirus for your viral type. And for bacterial, from here on out, when I am talking about the heat bugs, when I'm saying all of the heat bugs, I'm talking about H. flu, strep pneumo, and Moraxella calaris. Those are the 3 that are going to be the heat bugs. Those 3, particularly in the eye, H. flu is where you're going to see this. It's not H. flu type B, it's just Haemophilus influenza species. Then our allergic, and then kind of a secondary chemical cause. So you're in that first month of life. You are a neonate, and you're thinking, well, what in the world does this neonate have going on right now? Timing can help somewhat. So in the first little bit, you have to rule out if someone used silver nitrate on this baby, because that's going to be, obviously, will be the chemical reason in those early times. Then you have to decipher, and the timing can somewhat help. I think it's more helpful when it's later to help you to say, ooh, that's more of a chlamydia than anything else. But in that first week, if you have copious amounts of secretions in the eyes, that's when you start thinking it could be a gonorrhea. So if in a question stand you see the patient had a home birth, the patient had no prenatal care and was delivered somewhere, right? And they're trying to tell you they didn't get erythromycin, or mom had no prenatal testing and we have no status for STIs, and comes in with copious drainage. So Neisseria gonorrhea, whenever you have this, it has so much drainage, copious drainage. So you see that in a patient in the genital region, you see it in the babies in the eyes, copious amounts of drainage. Versus it's later, it's week 2 into week 3, and then I'm thinking it's kind of scant, I don't have good reason to have this, it's more likely chlamydia. And if I have a dendritic lesion, it's what? Yeah, HSV. Correct. As a reminder, that erythromycin ointment was for gonococcal, not for chlamydia. If you have that, and you have neonatal conjunctivitis that you do not think is viral in nature, you think it's one of the STIs, that's when I start thinking, what do I need to do with this baby a little different? So if it is gonorrhea, it sounds weird to a lot of people that you're going to hospitalize this patient for conjunctivitis. There is so much copious drainage, and the irrigation to the eye is so much that the baby can vagal down, or the baby can get hypoxic and go apneic from this amount of irrigation. Pretty rare, but it's just really intense. So what happens more likely is that the baby kind of has this overwhelming sense and then doesn't want to eat and gets dehydrated. So it's a whole thing. All to say, for gonorrhea, it's a whole process. So hospitalized for irrigation and IV antibiotics with septic. Chlamydia, scans a few weeks later. And this one is different because this is the first time we've seen erythromycin PO. The rest of the time, it's been an ointment. It's been topical. This is PO erythromycin. So make sure you catch that. Star highlight that. Pseudomonas is going to be your IV gentamicin. Do you remember what some of the side effects of gentamicin in kids are going to be? What are you saying? Ototoxic, right? So if you have a baby who has Pseudomonas conjunctivitis, they got gentamicin, what are you going to do then at their next well visit? Yep, an audiogram or some sort of a hearing screen. HSV, for the millionth time, acyclovir IV. And then you could do, if it comes back, you've done a culture and it really is Staph aureus, that's when you could do the topical erythromycin. So topical versus oral here for this. Viral. Now, the most common, so unlikely that you're going to see a whole lot of that. More common is that you're going to see kids, because it's a day that ends in Y, with adenovirus from every daycare, mommy program, church function, doesn't matter. Kids, it just runs through adenovirus. Very, very infectious. Starts watery, one eye, ends up bilateral. You can see some lymph node involvement. It should make sense why it's preauricular. That's the closest lymph node to the eye, just based on your anatomy. A lot of times, if you're trying to do supportive measures in treatment and you're trying to wash the hands frequently of a 3-year-old, good luck. I mean, you can try and you should try, but a lot of times it's not going to be sufficient. This is one area, so your book talks about over-treatment being common and excusable. That's a fancy way to say how the rest of us practice. So, you are correct as a provider to think to yourself, why would I give an antibiotic for a viral infection? You think to yourself, that doesn't make any sense. Why would you be prescribing stuff for kids with a viral infection? Yeah, so they're going to be touching their eyes a lot more and they give themselves a secondary bacterial infection. Why else? Parents, yeah. You want to know what kids can't go back to daycare and can't go back to school? All of them. So they're going to not be allowed back in school or daycare without some sort of treatment and no. So this is one that collectively as providers we've all kind of been like, you win system, and we will give you the drops. But it really does help because a lot of these kids, they will have adeno, then they rub their eyes so much that they end up giving themselves a corneal abrasion or a secondary bacterial infection. So low threshold to go ahead and, this would be one area to over-treat because the drops themselves are soothing, or the ointment, and so it really does help symptomatically either way. But for the record, you are treating a virus inappropriately with antibiotics. Do you guys remember the antibiotics that you treat with? Which one? Erythromycin is one. What's another one? Poly what? Polymyxin? Trimethoprim B. Yep, polytrim. So this is a good example then of what you're looking at. So the conjunctiva are quite irritated. If you have a kid that has, I can never look at this kid without my eyes watering, eye thing. But you have a watery drainage from both eyes versus what you're looking at below is more of that bacterial infection where you're seeing a more of a purulent drainage potentially than in one eye spreading into that second eye. At the end of the day, to me, they look very similar. And so most of the time, I'm not culturing or trying to decipher. I'm just going ahead and treating for the most part. Parents really want you to believe, for the most part, they really want you to, as the provider, to believe them. And this is one of those areas they are desperate for you to believe. And it happens in every clinic all the time, is people really want to prove of what's going on. So they won't medicate their kid and they'll come in with a fever, or they won't move the drainage away from the eyes. So you'll get little kids coming in with their like eyes crusted shut that are just like, you know, and you're like, it's okay, you can wipe the eyes, it's totally fine. So this would be an area I used to say, have some grace with parents and believe them if they tell you. This is again not one that no one's making up. Most common causes are your heat bugs, and then you guys nailed it. You get erythromycin ointment or polytrim. Please be able to tell the difference between the different types of conjunctivitis, so kind of a roll up between your bacterial and your viral. So those common bugs, those common etiologies, what it's going to look like. I'm not going to ask you about treatment because that's not fair, because I just told you that we treated and over-treated. Your next decision as a provider is going to be, do I want to give ointment or do I want to give drops? So that's an interesting question. If you give ointment, what happens to people's vision?
Blurry.
It's completely blurry. What's going to happen if you give that to a 3-year-old?
Rub it out of their eyes.
They're absolutely going to rub it out of their eyes. So you put ointment in a little bit of an older kid, it's not going to work super well. Maybe at night, but probably not. So usually for me, if they are over 1 and really over 9 months-ish, I'm going to go and prefer drops because it's a quick drop. As long as the parents are comfortable with that. The younger the baby, I'm going to be doing the ointment. So whatever you're prescribing, just make sure it makes sense for that patient. The two I want you to be familiar with are the polytrim and then the erythromycin ointment. Your allergic conjunctivitis. So the biggest thing for this is that the onset at the time of symptoms starting is bilateral. And that should make sense, right? Because you're not just having pollen just like hit one eye, or like animal dander like only hitting the right side of the face. So allergic symptoms come on bilaterally at the start of symptoms. So it's good for questioning. That's good if you see that in a question stem to help decipher. The other thing that on exam is going to look a little bit different is cobblestoning. So if we think about old streets that were made of brick, and you kind of saw how they all kind of popped up like that, it's a sign of chronic inflammation. So you see that more with an allergic type of conjunctivitis than you do with an acute infectious type. For this, let's see, I've never in my entire life seen anyone give topical cromolyn. We have taught you that in Farm, and probably heard it in Poem. I would be hard, if you found someone, one of your instructors who has given cromolyn, I don't even know. I'd pay you or something, because there's nobody here who's doing cromolyn. It's indicated for it. The dosing is like 4 times a day, so no one's using it. You can use vasoconstrictors, your NSAIDs, your antihistamines. They don't work particularly well for eyes. Particularly for eyes, your nasal steroids are actually first line for your eyes. I should move that into the first bullet now that I'm looking at that. But the bottom bullet of nasal steroids for eye symptoms is really what your first line treatment should be versus your NSAIDs or antihistamines. So oral antihistamines don't work very well for the eyes. So if you're thinking to yourself, slam dunk, I know this is allergic, I'm going to give cetirizine or loratadine, and they come back and they say, my eyes are still bothering me, and you're like, I don't know what's happening. It just doesn't penetrate the eye well. So nasal steroids are going to be your first line for the eye. So something just if you know this information and have a roll-up, there's going to be something on conjunctivitis and differentiating the different types. So it will be a conjunctivitis question. Don't know when I started. I'm trying to finish up this one. So what I was talking about with the limbic sparing, so if the hyperemia is going all the way to the pupil, one of the highest things is that you need to expand your differential. So is this a ciliary flush and has some serious pathology, it's a lot more pain usually to the patient? Or do they have some other itis? Is it a problem with the cornea, with the uvea, with the chamber, somewhere else? So it's not just the conjunctiva that can be inflamed or infected. Any of the other parts of the eye can as well. Those are a little bit more concerning and need some urgent referral. If you ever have pupillary involvement as well, that would be another one. So remind you what we're talking about with limbic sparing versus that ciliary flush that goes all the way up to the pupil. Limbic sparing. I always forget I have a pointer. I really like it. Versus ciliary flush. You guys want to take a break now or kind of press for another 5? Okay. Take a break, come back in 10. Okay, so we got through conjunctivitis. Not all things being conjunctivitis. Another option would be, do you have blepharitis? So is your eyelid margin irritated or inflamed? So if you guys already done seborrheic dermatitis in derm, it's functionally that on the eyelid, right around those hair follicles of the eyes. So you treat it very similar for that. So you have seborrhea inside the meibomian gland, and then the dysfunction of the gland itself. So these kids, if they're older, there's certainly talk about if their eyes feel like they're burning or it's an irritated feel. The younger kids oftentimes will just do a lot of blinking because their eyes are burning and they're really, really irritated. This will cause little babies to just rub their eyes a whole lot more. So if they're doing it outside of when they're tired, they're just frequently rubbing, it's a lot of sign of that dermatitis, seborrheic dermatitis of the eyelid margin. Your treatment is eyelid hygiene. So you take your tear-free shampoo, water it down a little bit, and take a Q-tip and truly do an eyelid scrub on the eyes. For the babies, be sure that it is tear-free shampoo. I went down a little rabbit hole about what tear-free shampoo is. It's actually kind of interesting. It's a bigger surfactant molecule, and they change the pH so it's more in line, it's above 7, so that it's really not burning their eyes. So I was like, that's kind of interesting. So when we talk about other things that we'll use in derm for kids, like ketoconazole shampoo, for example, or a steroid shampoo, those ones aren't tear-free. So making sure you know the difference of what you're using for the kiddos. You can also do warm compresses and topical antibiotics if the eyelid hygiene isn't working to get rid of that staph burden. And then dacrostenosis. So stenosis is not stenitis or any kind of itis. So this is not an infection. And so that's what I want you to take away, if nothing else from this slide. This is not an infection. We see this all the time in kiddos. So tiny new little babies coming out. The lacrimal duct itself is teeny tiny and it's stenosed down. It hasn't really opened up yet. So you don't have a drainage channel. So if your eye is continuing to make fluid, you can't drain it. What do these babies come in with this presentation like?
Crying.
Constant tearing. What happens when you mix and that dries? What does it look like to the parents? Yeah, it looks like pink eye. It looks like there's a constant discharge and a constant crusting. So that crusting is really just some of the sebum mixed in with some of the tearing. And so it's not infected at all. It's just this constant crusting and constant tearing of this baby because the lacrimal duct is stenosed down. They don't have a channel to be able to drain the eye. So your first line treatment is, how can we get this channel to open up so that this baby's physiology can flow? So duct massage is going to be your very first thing that you're going to do before you do any kind of other treatment for any type of infection. The duct massage, you should be able to feel it on yourself. You should be able to feel a lacrimal sac, kind of that small pea-sized nodule that you're feeling. You feel that on the baby, and then you move down, pressure in and down. And you do that several times on the baby with a clean hand to break up that lacrimal duct and to help it open up that obstruction. So a lot of times they'll say warm up a washcloth, give a few seconds of heat, and then do that massage a few times a day to help that system open up to be able to drain. So your first line for a dacrostenosis, duct massage. What happens when the channel is then infected? So the infected side is when you get this cystitis. So that is truly when now you have this inflammation and infection of that. That's going to look different. The copious amount of drainage, the irritation of the conjunctiva, the irritation of the baby, right? So you're going to see that it looks more like an infection. You can certainly try the massage and the warm compresses first. You can try your tear-free shampoo again for some of that eyelid hygiene. You can try your topical antibiotics, but if it starts to get severe, that's when you want your oral antibiotics. It would be with Augmentin. It's going to be amoxicillin in your first line. I'm not going to test you on the antibiotic. But the way then you can determine, is this severe or not? The best way I know how to describe it is if the canal, if the lacrimal duct looks like there's another eyeball in it, it's severe. Right? So you're looking at that baby, both of these babies, and you're like, yeah, that looks like a third eyeball right there. That's severe. So if you're thinking that, you really need to do oral antibiotics. If they're not improving in that first 24 hours, so anything with the eye where you're giving oral antibiotics, just rule of thumb, if you're giving oral antibiotics to anything around the eye, see them the next day. If the next day they're not significantly improved, ophthalmology. 24 hours, your textbook is 24 to 48. In practice, see them the next day or have plans for follow-up the next day. Probably remember these ones, your hordeolum versus your chalazion. So the hordeolum or your sty is an infection with your, most of the time, Staph aureus. A little bit deeper than you had with that blepharitis into the glands of Zeist or those meibomian glands. Very, very tender, very painful, often recurrent for these kids. So if you see it once, a lot of times I just go ahead and give the parents a plan to continue to treat at home if it pops back up. So NSAIDs, warm compresses, trying to get that infection out of those deeper glands. If it's been more than a couple weeks, sometimes they need a small incision and drainage into that area, so ophthalmology can do that. Most of the time you can manage these as an outpatient. You might pop up, be very painful at first, and then continue on their way. Compare that to a chalazion. So this one's a lazy thing, meaning it's not really going to hurt that much, it's not really going to do that much, it's just going to sit there chronically. It's pretty lazy. So this one shouldn't be acutely tender, shouldn't be acutely erythematous, should just kind of hang out like a bump there for a while. Same thing if it's hanging on, but this time for several weeks to months. Over to ophthalmology again, you might need to drain this. This one's warm compresses don't help as much just because of the chronic nature of it, but certainly something to try at the beginning. Just a reminder, the difference between hordeolum or sty versus chalazion. I don't know why I really like this particular little protein. Into the cellulitis. I don't love how we as providers talk about this. We talk about periorbital versus orbital. It's more correct to say preseptal and postseptal, but that's just me. I will forever die on that hill, so I'll put it in the slide myself. So periorbital or preseptal. It's obviously in front of the septum of the eye. It's really a cellulitis of the skin around the eye. Really functionally all this is. Cellulitis of the skin around the eye. Most of the time with Staph aureus or strep, any of your skin bacteria, typically kids under the age of 5. And when I've seen this over and over, the way that I see it present most of the time looks like the kid drew on really bad pink eyeshadow on one eye. So kind of the way it presents every time. It just looks like their eyelid has pink eyeshadow on it. Cellulitis of the eye. Certainly it can look more pronounced, but when you see it in general, that's oftentimes what you're seeing. The two biggest things for your, three for your physical exam. Number one, their vision is intact. There's no change in vision. There's no proptosis. The eye is not being pushed out, and there is no pain with the movement of the eyeball. You have to have those three things. If you have vision changes, proptosis of the eyeball, or it hurts to move the eyeball, you're really functionally out of that preseptal or the periorbital phase, and you know that something is deeper because it's now affecting the eyeball. If you don't have any of those three big red flags, you can treat this as an outpatient. You really don't need a CT scan because your physical exam has already told you there's nothing deeper. There's no pain with the eye movement. There's no visual acuity loss. Nothing's pushing this out. So you can use a lot of things, cephalix and clindamycin or amoxiclav. Amoxiclav is the one to circle. Really, in practice, we're using amoxiclav for this. You want to make sure you have some sort of increased gram-negative coverage for that. What's the big side effect of amoxiclav?
Diarrhea?
Diarrhea, yes. Copious amounts of diarrhea. So something to be aware of for these
Just got
kids.
so many children are augmented.
And this would be the one, again, it's right around the eye. I see these kids the next morning. So it doesn't really matter what time of day I am seeing them. They are my first follow-up in the morning. If they are not significantly improved, off to ophthalmology or off to the ER for then a scan, because they should be better within that 24 hours. I think the left side kind of looks a little bit more like typically what I see versus the right side. The right side would have me a little bit more worried, but as long as the visual acuity is okay, there's no proptosis, and there's no pain with the eyeball, really still is a cellulitis. Most of them will present like that left side where it looks like a bad makeup job. So I kind of want you to think about it. Orbital or postseptal is going to have then the opposite. You're going to see that they do have vision loss, they do have proptosis. It's very painful when the eye moves. So it's usually it's seeded from the sinus infection or a sinus. There's often those Heme bugs, so yes, it could still be strep or staph, but you're also going to see that Hib or Moraxella are also going to be things that you see with this. If you get a picture of the sinuses, a lot of times you'll see where it has seeded from the sinus down into the orbital cavity. You can see that chronic inflammation and then infection into the orbital space. This one's a true medical emergency. So people go to the emergency room all the time for minor predicaments. They are not true emergencies. The true emergency is what? Life, limb,
eyesight.
or eyesight. Eyesight is compromised. So for that reason, this is a true medical emergency. They need to be sent to the hospital. They need to have blood cultures drawn from 2 different sites. 2 blood cultures to see, can we get this bacteria isolated better for treatment? And you haven't seen me say this yet at all, these kids need a CT scan for surgical planning. So ophthalmology potentially is going to have to go in and surgerize them for true orbital cellulitis. They need that CT scan for surgical planning. What you're going to start after you get those blood cultures, vanc and ceftriaxone or cefotaxime. That gives you your encapsulated bacteria coverage, that gives you your gram-negative and positive, and then that gives you your MRSA coverage. So those 2 in conjunction. So this would be our real first true emergency that we've talked about would be orbital cellulitis. Some complications that we see, those cavernous sinus thrombosis, very rare in kids, but we do see it. You can see abscesses that will build up and then potentially chronic vision loss. So please be able to distinguish the difference between those 2. put charts throughout as we go. If you feel like you've got the run up pretty well, skip over the charts. If that's easier to study for you, go for those. I love this picture because it really explains and it really helps put it into perspective what we're talking about with preseptal versus orbital cellulitis, where you're looking at that preseptal is just that superficial skin, so it can look potentially exaggerated, but it's really always in front of that orbital septum versus in that orbital space, and why you get proptosis of that. So let's practice. What do we see in this kid? Does he look sick or not sick?
Sick.
This kid looks sick. Okay, what do we see with the eyeballs? You see some edema. You see some erythema. You see some proptosis of that eye?
I think so.
Yep, you got some proptosis. Just guessing, so we can't ask him, does it look like that would be painful to move his eye?
Yes.
Yes, and then what other thing gives this one away?
The lip.
So the widened nasal bridge, yep, significant erythema. Even more basic than that, use all your context clues. The hospital gown, yes, right? So when you are there for your pants, there are sometimes they will give you things like this. Use all of your context clues. You're like, what should we do? Well, they're in a hospital gown, so hospitalize them. Let's take that in. All your context clues. We made it through the eyes. Yay! Onto the ears. Oh, this whole section of acute otitis media. We can get through acute otitis media, we can call it for the day. Okay? So, my bread and butter. The whole reason that pediatricians exist, right?
Pretty much.
Otitis media. So, as a reminder, when we're talking about otalgia versus otorrhea, one is pain, one is drainage. See, people get those ones mixed up often. As a reminder for that anatomy where we're talking about. We're talking about the middle ear behind the tympanic membrane. Your eustachian tube in kids, we'll have a picture here in a minute. Very different anatomy, the way that the physiology works because of that anatomy in a child compared to an adult. So, I need to change these two. Let's start at the bottom. When we're talking about definitions, see, people get these mixed up frequently. So the first thing is just, do you have fluid in that middle ear space? Yes or no? If yes, you have a middle ear effusion. That should make sense. The bottom one. Do you have fluid there? Binary, yes or no. Not infected fluid, just fluid. So yes, fluid, middle ear effusion. You can have it there for several reasons. Maybe it was an old otitis. Maybe they have some stuff going on. Maybe that's just residual. We can see that there, but a middle ear effusion is thing number one. Fluid, yes or no. Then the second part. Do I have an otitis media with effusion? So what that is really looking at is, do I have fluid there? Is the kid sick? Yes. But do I think that's the cause of their sickness? Yes or no? And in otitis media with effusion, the answer is no. I don't think that's the cause of why they're sick. So the fluid's there and they're sick, not the cause. Versus an acute otitis media, there's fluid there, they're sick, and this is the cause. This is why they're sick. So I need to reorder those because that doesn't make sense in the way they are. So sorry. So if you can understand those three things, we are set to go for the rest of this. So functionally, where we should start is in the middle of this chart. Do I have a middle ear effusion? Yes or no? So that no acute inflammation, I can be down into that. This isn't the cause of this. And actually, I should reorder this. So don't worry about this slide. We will come back to this in the end. Okay? So a normal TM, then, when you see this, totally normal. You have your light reflex. Cone of light, there's no erythema, there's no hyperemia, there's no fluid behind it, we are good to go. In that serous or middle ear effusion, you see the fluid, you can see the bubbles, you can see the air fluid levels. And then down when you get to acute otitis media, I'm going to let you in on a little secret. Okay? We used to play a game in residency. And the game was, is it an acute otitis media? Or is it an infected cervix? Okay. So if you have to ask yourself, is it an acute otitis media or an infected cervix? It's an acute otitis media. If you're not asking yourself, is that a cervix? It's probably not an acute otitis media. Okay? You're probably in the effusion world or a serous otitis media. Okay? So please, in your mind, for the rest of your life, when you're looking at an ear and when you're trying to decide, do I want to give antibiotics to this kid? Versus just looking at, is it red? If you're looking in the ear and you're like, that looks like a mini cervix, that's what you're looking for. That's going to be an acute otitis media. When you're looking at infected cervix, looks like pap smear, that's what we're talking about. Who's at risk for this? Well, young kids, because of their anatomy, small space, it is horizontal. So if you look at the middle ear compared to the eustachian tube and the way their face looks, it's horizontal. Versus ours, it's pretty vertical. Which one drains better?
Vertical.
The vertical one. So you have these young kids, this horizontal tube doesn't drain very well. We see it more often in low socioeconomic sects, more often in formula-fed babies. Why?
They don't have mom's immune system.
They don't have mom's immune system. So they don't get those antibodies to protect against some of those bugs early on. Tobacco smoke exposure. What happens if you are exposed to tobacco smoke?
Cancer.
Everything, yeah. What specifically is going on here? It's not that. It's just a chronic inflammatory state, puts you more at risk. Daycare attendance, because kids are gross. Respiratory, anything, because you're going to potentially have that be a stagnant pond that cannot drain for those little guys. Pneumococcal, we talked about that the other day. Remember how many series we are preventing these days?
23.
We can go up to 23, typically 20 for the average kiddo. And then, is there something already that's putting them at risk? So we talked about trisomy 21, specifically having sensory neural and craniofacial abnormalities of the structure of the face, more at risk for that. Here's that example of that anatomical difference. So those kids who have the different facial structure where they don't have as much vertical drainage, that horizontal drainage puts them at risk for not draining, and thus creating a functionally stagnant pond behind that TM. Most of the kids in the world, or at least in the US here, about 80%, so 4 out of every 5 kids is going to have an ear infection with otitis media by the time they are 3 years old. So this is what keeps me in business, the otitis media. It's one of the leading reasons right behind fever that we see kiddos for clinic, and the top reason that pediatricians are giving, or any providers, are giving antibiotics to kids is the otitis media. Recurrence, we'll talk about when do we define recurrence, but that recurrence is going to be an indication for a tympanostomy tube, or those pressure equalizing tubes. You'll see it in the chart as PET, pressure equalizing tubes, or an adeno, to have their adenoids removed to help with, again, some of that drainage. Your bacterial causes are those typical heat bugs. So the same ones over and over, same for sinusitis, same for conjunctivitis, same in the bacterial space here for otitis media. Not as much for viruses. So the problem with this, diagnosis is often very difficult. Sometimes you cannot see the TM. There could be too much cerumen. The child is flailing around, screaming, so it looks really red. So there is often underdiagnosis of this and often overdiagnosis of this. I see this a lot when people don't know what else to do. They don't know what else to diagnose. They'll say, oh, the ear's a little red, maybe it's an otitis, and here's some amoxicillin. And what is that one disease that we don't want to do that for because it's going to look like an amoxicillin allergy? The fever that rashes is what? No. Close. Which one is the fever that rashes?
The second?
It's really close. What? Roseola, yes. Roseola. Yep. So that would be one of those indications. If you are like, maybe it's an ear infection and it's roseola, now you've set them up to not be able to have amoxicillin. So, often under or over diagnosis. So if you're really going to say, yes, this one is an acute otitis media, this is the source of the infection, I'm treating this one, they need to have three things. Number one, they need to be sick. So they need to have acute signs that they are actually sick. That's the acute part of the acute otitis media. Second, they have to have a middle ear effusion. There has to be evidence that there's something in that middle ear that shouldn't be there. So is the TM bulging? Is it got, have you lost the cone of light? Has something changed with that anatomy? The mobility decreased. And then third, is there some sort of middle ear inflammation? Because again, they might have fluid, they might be sick, but is that the cause of why they're sick? So they have to have that third area of, is there middle ear inflammation? Is the TM erythematous? Is there true ear pain or otalgia? I think most clinics do not have a tympanometry anymore. If you find it and have it in clinic, it is a great way to help you diagnose this. Okay? So if you're looking at A, totally normal, TM. B, you've got a little bit of fluid buildup. C, you've got more fluid buildup. D, you're starting to look like an infected cervix. D is when you're starting to look a little bit more like that, but you don't necessarily see the hyperemia or the inflammation of that yet. This one though, you're thinking to yourself, that looks like an infected cervix. That's a true acute otitis media. So maybe that doesn't work for all of y'all. Maybe you'll never forget it. We'll see. Okay, your treatment. So the first thing that parents are going to come in for is that their child hurts. So please, for the love of God, treat the pain that the kids are coming in for. Oftentimes we'll be like, here's your amoxicillin, and the kid for a couple of days is still in a lot of pain. So make sure you give your age-based acetaminophen and ibuprofen. What was your dosing range of ibuprofen? 5 to 10 milligrams per kilogram. What about acetaminophen? 10 to 15, correct. Antibiotics, you can do a lot of different things with these. So we'll look at what do we do versus when do we watch and wait. How many % of parents want to watch and wait? Yeah, like 1% of parents. It's not, but we will talk about that. Start this one because you'll need to know this one. So, if you are less than 6 months and you think that this is an acute otitis media, you treat all of those ones. So we're not talking about under 6 months. We are talking about the age range mostly between 6 months and 2 years. So the ones that are highly likely to get this, their anatomy is primed to have this be a pathology, and they are susceptible to having a reaction to amoxicillin if we give it. So, first things first. If you are any age and you have otorrhea with this, so you have a perforation, you have stuff coming out of your ear drainage, and an acute otitis media, you are getting antibiotic therapy. Doesn't matter how old you are, you're getting that. Doesn't matter how old you are, you have unilateral or bilateral acute otitis media with severe symptoms. So how do we classify severe symptoms? It's in the note of this slide, but it is if you have a fever greater than 39 degrees centigrade, so it's more than 102.2. If you have had symptoms that are there for more than 48 hours, or severe pain that is classified as a severe infection, all of those guys get antibiotics. If you have bilateral, but without severe symptoms, and you're between 6 months and 2 years, you also get antibiotics. But if you're older than 2, well, you can talk to us a little bit more. And maybe it's not severe, so your body's going to clear it. And your anatomy has started to change a little bit, so you might drain. So that would be an indication over the age of 2, not severe symptoms, to talk to the parents. Do you want to watch and wait for a couple of days? Do you want to start treatment now? And then for both sides, if it's one ear, no severe symptoms, then you can have that conversation either way. So either watch and wait or go ahead and treat. How many parents do you think choose watch and wait? Not a whole lot.
All zero.
Not zero, there's a few, but not many. This gets you down to that same pathway if you didn't like the chart before. Okay, this one, we're almost there. This one, I need you to know these specific things. Star, highlight, underline, highlight this one. I need you to know amoxicillin. I need you to know amoxiclav. I need you to know ceftonir. I need you to know ceftriaxone. And I need you to know azithromycin. Because these will be ones that you will actually use going forward. So, your first line treatment, is this going to be high dose or low dose amoxicillin?
High dose.
Why? Correct, because only group A strep is going to be your low dose. So do we know that this is group A strep?
No.
Nope, what's it more likely? One of the heat bugs. Yep, so I'm going to do high dose. So high dose amoxicillin, your first line. So I want to do that. I'm not going to ask you how many times a day and how many days. I want you to know the medication and your dose. Those are the things I want you to know. Okay, so let's say they have failed amoxicillin. Your next line is to add clav to it. They're saying they have a resistant bug. They have a species that is not covered by your beta-lactam alone. So I am doing my high dose amoxiclav at 90 mg per kg. Let's say they have a amoxicillin allergy. They can't have that, or it didn't work. And you're going to go up to ceftonir. And ceftonir, for whatever reason, has the oddest dosing in the world. It is truly 14 milligrams per kilogram a day. Strangest dosing. Never understood why it is not, but it is. And then your last one that you're going to do before you're going to hospitalize is you could do ceftriaxone, 50 milligrams per kilogram, up to a gram, IM or IV. That's really where we kind of top out in the clinic, where we're coming in and bringing them in for 3 days in a row for an IM shot. And then if they have a beta-lactam allergy, they cannot have amoxicillin or ceftonir or augmentin. That's when they get the azithromycin. So those are the ones that in real life, you will use all of those. Okay? Let's talk about, see, we already said amoxiclav. What was that main side effect? Diarrhea, yes. And we're talking copious amounts. So they will then come back with a diaper rash from the amoxiclav and severe GI upset. Ceftonir, interesting side effect. When you give ceftonir to a child, the poop turns this like Sedona red clay color. And it really freaks people out, and they think that their child is having bloody diarrhea. So if you don't prepare a family for the red, Sedona red clay stool that they're going to have, I guarantee they're going to come back and freak out because it looks like the child is having bloody diarrhea. So at least 1 month for that. Okay, Peach, amoxicillin, amoxiclav, ceftonir, ceftriaxone, azithromycin. Afterwards, that's a hard place to drain. So even if it's not infected anymore, there's often still fluid in that middle ear. Very difficult to drain. Can take months to drain. Sometimes up to that 3-month mark. So all things ear, the definitive care, we're really looking at 3 months. So when we said the newborn screen, getting them to definitive care by 3 months. Same thing here. After 3 months, if you're still having an effusion that you can't drain, that's when you would say, I need some ENT help. So we're looking at this at well visits and then at least a 3-month follow-up after an acute otitis media. Because if not, you end up seeing some conductive hearing loss associated with that. That's when an ENT will sometimes go in and put those pressure equalizing tubes to help with the drainage. The tubes are colored usually, and that's helpful to know. So if you're looking in a kid's ear and you see something that's blue, or green, or yellow, or red, or whatever the color is, I usually tell the family, hey, just so you know, your tubes are blue, or your tubes are whatever color it is, so that when they fall out, the parents aren't like, what is this? You know, if they know I'm expecting some red thing to fall out of my kid's ear, and a red thing falls out of the ear, okay, then they know. So I usually tell them the color. Okay, so now you're trying to decide, is this acute otitis media or otitis media with effusions? We were back to that very first question. Do I treat, or is this a side effect of whatever else is going on with this kid? So really the biggest way that you're trying to decipher this is this the source of infection or not? So most of the time they're coming in with a URI, upper respiratory infection, and you're deciding, do I treat or do I not? This is going to be very, very common with every URI. Doesn't mean you're going to treat all of them. So an incidental finding, have they had any speech or hearing issues in the past that you would be more aggressive to treat if they had? Is this the source and they're talking about that otalgia or not? If not, and you just happen to know that there's some fluid and a little bit of erythema, but they are not bothered by it, totally okay to treat the URI and follow up if something changes. How do we say when it's recurrent? So if it's been less than a month since they came back, that is a recurrence of an acute otitis media. At that point, you have to decide, what am I going to do? When am I going to treat this? So let's say the child came on March 1st, and you diagnosed AOM. March 1st. They come back March 15th, finish their 10 days of antibiotics. What antibiotic are you going to do next if you had started with amoxicillin? Augmentin. Yep. Let's say you diagnose it March 1st. They come back to you April 15th. What medication are you going to use then? Amoxicillin. Because you're saying it's been more than a month, this is more than likely a new infection. Correct. If that's happened more than 3 times in 6 months, or more than 4 times in 12 months, it's considered recurrent otitis media, and then that is a referral for ENT to have an evaluation for tubes. So parents will often, and I totally get it, they will think, this has happened twice, or this happened 3 times in a year, I really want to go see ENT. It has to be 3 in 6 months, or 4 in that 1 year period. Complications, it can seed other places. So the thing that we really don't want is if it seeds into that mastoid area. So always checking to make sure they're not tender over the mastoid area, or if the ear is displaced. So if you have normal set ears, and now suddenly it's posterior rotated, or it looks like the pinna has moved, be a concerning sign for your mastoiditis. That would be another indication to go ahead and get a scan if you're really seeing that, and call ENT right away. The other one would be a cholesteatoma. So if you are seeing, it looks kind of yellow, whitish. If you're seeing that when you're looking at the TM, it is looking like an epithelial-like growth that you're seeing. ENT will take care of that one too. And then all the big bad things that you're thinking. It can seed anywhere. So is it going to cause an abscess or an empyema? Is it going to cause a hypercoagulable state and you end up with a thrombosis? All of those ENTs. This is more of a phase 2. I got really fancy with charts here for a while and I was really liking them. Doesn't have any different information. All roads lead to amoxicillin. Okay? So when you're looking at this, what do you see?
Fluid.
You see some fluid. So what do you already know you have? You have the middle air effusion. Okay. What if this was a 3-year-old well visit?
They have a middle ear effusion.
They have a middle air effusion. When do you want to check again?
6 months?
Not 6 months.
3 months?
3 months. Yeah, I want to check in 3 months. Do you still have that middle ear effusion? Okay. But yeah, nothing in there. What about they come in with this? This child is, let's say, 18 months, and they've had a fever, and they have a runny nose and kind of a cough. What do you think about this? How would you diagnose this? Yeah, serous otitis media, right? It's got some kind of cloudy fluid in there, but do I think that this is the source of this kid's infection? No. What about that?
Acute.
Looks like a cervix, right? This kid comes in probably saying their ear hurts and a higher fever, so I'm going to treat that. Correct. You guys look like your souls are coming out of your bodies. Okay, let's stop here. We're having good here, but